Thank you very much. You pretty much learned everything about me, and if you were here a little early, you probably learned a little bit more about myself on this CD. And that's pretty much, if you go to YouTube and type in Valley Vascular, you'll get a chance to see that video. First of all, I am extremely grateful and thankful that every one of you took the time off. Probably the first day, probably for the whole week, where the weather is actually pretty nice. And so you're spending it with me this evening. So I think that's an honor. And of course, I must say thank you to Fresno Heart Hospital for sponsoring this, because community awareness is very, very important. It gives the community an opportunity to know what's happening in terms of patient care in certain specialty, whether it's your medical doctor, whether it's your cardiologist, whether it's your heart surgeon, your vascular surgeon, your internist, and even your family practice. Because medicine is changing very rapidly, right? I mean, if you remember in the 20th century, between 1960 and even up to 1990, it was medicine was almost stuck in the same everyday routine. But soon as we hit the 21st century, technology has advanced so rapidly. And I always seem to compare it to the movie industry. And, and the reason why I mention the movie industry is because the movies and technology in the movie industry has improved significantly because of the computer software. And so imagine watching television now in 3D, movies, So with that technology, even the ultrasound, if any one of you guys work in the healthcare or physician office, if you sort of remember when you go visit your doctor, even when you went for ultrasounds, remember those big old ultrasounds? They were like this. Ultrasounds are very small now, and they're portable now. They're even handheld now. Parts of Africa, GE is promoting handheld ultrasounds. So software has changed, right? And technology. So we can do amazing things. We do telesurgery now, robotic telesurgery. So technology is very, very important. So a place like Fresno Heart Hospital, it's important for them to promote to the community what's happening and to be aware. So that's the whole point of the community awareness. That's where you know what's going on in your community. So I think that is pretty cool. Now, are you ready? Not ready for Monday Night Football, but are you ready to learn about venous disease? All right? So I want to try to keep you guys up on your toes. I usually tend not to stand behind a computer and speak. I like to get very interactive with my audience. Before we talk about, because the issue is with vascular disease, it's a broad field. Vascular surgery is a very, very broad field. And when you sort of narrow it down and you take an artery and a vein and then you look at all the possible disease process in the venous system and all the possible arterial disease that exists in the arterial system, you have a huge amount of diagnosis and treatment. So the neat thing about this profession is you can be treating a vast array of disease, whether you're dealing with dialysis access with dialysis patients, even when you're dealing with wound patients. There's a huge pathophysiology in terms of venous as well as arterial related to these wounds, right? And many of us grew up in an era, besides myself, but many of you grew up in eras where a wound was just something you live with. And there was really not much technology. And again, in the last decade, literally in the last decade, the technology alone just to deal with wound has just exploded. So, when I was in residency and people came in with arterial disease or, the so-called vascular disease at that time, you went for bypass. And you spend maybe 9-10 days in the hospital, and then you go to the nursing home and you spend 6 weeks and you go through brutal physical therapy, and then you come home. Well, that doesn't really exist. I mean, there are a few patients that have to have that procedure, but in 2012, minimally invasive, these procedures are done as outpatient, and you go home the same day. So many of you, I'm sure many of you may have experienced a cardiac cath, a simple puncture, right? And you can go down into the legs and you can open up blockages now and return and heal. And these are actual patients of our practice. Varicose veins, right? So the idea is, where does venous disease stands among all the vascular disease, right? Because when you sort of think of vascular disease, the first thing probably comes to the mind is cardiac, coronary artery disease. right? Because many of us or many of our family members or relatives or friends or someone that's pretty close to us have had some form of issues with cardiac, whether they had a cardiac stent or a balloon angioplasty, or they've had it done and they end up having to go for bypass. So cardiac disease. Now, when you sort of look at these numbers, you know, even all the way, if you go back into the literature, for those who like to read of stories of historical importance, so for centuries, and again, no one really had a true understanding exactly how to treat venous disease until the last decade, and more importantly, even in the last 5 to 7 years. But the number I want you to look at is 24 million Americans living with venous disease. 24 million Americans. 6 million with skin changes. And more importantly, look at those patients that has to deal with venous ulcer. Right? So now, in this era that we live in, we screen. Right? We screen your carotids to check to make sure you don't have blockages. We don't wait till you get a stroke and then finally check your carotids. We screen you now. We screen you for abdominal aneurysm. We don't wait till you rupture and then decide, let's check and see what size aneurysm you have, because by the time we check it, you're already dead. The mortality is almost 90%. So even the patients who make it to the operating room, even a greater than 70% of those patients will die from complications. So you know if you have an aneurysm and you rupture, the chance of survival is very, very, very dismal. So that's the whole point, screening patients. Look at the cost. And it almost looks like a very simple disease, right? But look at the actual cost. When I was in residency, I remember seeing patients when I was a student, an intern or resident, the same patient, right? The same dressing over and over. So, you know, it heals, it feels better, but then it comes back. And you'll see why. Why does this disease come back? Why is it that somebody has a venous ulcer, if they spend 6-8 months in the doctor's office, it finally closes off, and then maybe 6 to 8 months to a year, it comes back. And it never comes back the same. It always comes back worse. Very expensive. One single diagnosis. And the one thing from this slide is there is no disparity between men and women in terms of, women get venous disease more than men. It's sort of a little bit of a misnomer. If there is any difference, it's 1.5 to women to 1 ratio. It's really no difference. Age, yes, it is a disease. You'll find it in women, over the age of men and women over the age of 50, but it doesn't exclude the younger populations in their 30s and 40s, and we see a fair amount of those patients, and it can go all the way up to 90. Right? Now, who are the people who are going to get venous disease, right? There's a subpopulation of patients. One, it's always going to go, number one, it's always going to be your family history, right? You remember mom and dad had venous disease. They were working, your generation, right? All the way back into the Depression. They would work. They worked hard. They were always on their feet all day, right? Because they had a major commitment to this country. So they worked. They were always on their feet, whether they were in the mills or in the plants or, the coal mines or building tanks and warplanes. These people were working. They were standing all day on their feet, all right? So you may remember when they came home, their foot was swollen and they had all these big bulging varicose veins, but that was the least of their problem, right? They had to work. So family history is a very, very important thing, just like any other medical diagnosis. The second one is a very important one. I'm going to skip past trauma, but patients with deep vein thrombosis or a DVT or the so-called clot in the leg. And I'll show you later on why does DVT responsible for that. But the diagnosis later on when you have DVT and you end up having venous problem is known as post-thrombotic syndrome. And so the opposite version of the great saphenous is the small saphenous, and that runs in the back of the calf, and it joins the major venous pipe in the leg. Those are the only two veins that the good Lord allows us to mess around with. The other major venous pipe in there, we can't touch it. If we mess with it, you lose your leg. So that's your vein of the leg 101. And so what makes a vein function? How does blood get back to your heart, right? Because when your heart squeezes, it leaves the arterial system and it goes its merry way, right? Goes up to your brain, it goes up to your arm, supports everything, it goes down to your leg. But it has to come back up now. The blood must come back up. So that's your venous system. So I always tell my patients, when the good Lord is sitting there with all his angels and they're trying to figure out, well, we need to come up with a master system. Well, he gave us gravity. So now you have to counteract gravity. So that means we have to put valves in there, because otherwise gravity will pull all that fluid down. So, hey, why not put some valves in there, and those valves will point upwards, and it will help propel the blood, and it'll keep going up. Except they forgot to tell us that many of us will have malfunction of those valves, and we'll all have problem with venous insufficiency. So there's two systems in the leg. It's called the superficial system, which is the great saphenous vein and the small saphenous vein, and the deep vein system, which is, many of you are familiar when you get deep vein thrombosis. But believe it or not, both systems, just like any highway or tributaries, they always have interconnections. So it's just like a highway system. The superficial system is connected with the deep system by what is known as perforators, or channeling branches that interconnect. And so the mother pipe system is like many of us, I don't really want to work hard today. Why don't we kind of dump it on the other system, do some work, So when these valvular systems are no longer working, the deep system is saying, hey, you're not working, guess what? Why don't we shunt some blood over to you? And then that system is basically responding by, well, I'm not supposed to, I have my own job. I'm not supposed to take up all this extra fluid. So it becomes overwhelmed and overburdened. And this slide pretty much tells you exactly what's going on. Here's your normal valve. So every 1/100,000th of a second, that valve is open, closing, open, closing, open, closing. The blood is going up. So that constant dance of the valve helps propel the blood. The other system is your calf muscles. Those veins all traverse through big muscles. It comes up. So when you're active and you're walking, your muscles are constant in a state of contraction. That additional contraction helps propel, right? So that's why it's important when you have venous insufficiency that you don't stand for a long time, standing there, Even when you're sitting, your legs are still hanging down, right? You'll notice that your leg and your ankle gets puffy and swollen, and it's usually sort of, as the day progresses, you always sort of notice, gosh, my ankles are all puffy, and by 3 o'clock in the afternoon, I'm dragging my leg. It's kind of heavy. So when the valves are closed, it prevents the blood from refluxing, going the opposite of flow. But if your valve is closing, but it tries to close like that, now you have a two-way system. Your blood is always going to go up one way or the other, but it's always going to reflux as well. So now your one-way system now becomes a two-way system, right? Or the way I talk to my patients, I tell them, what's the difference between, let's see what happens. It's a quiz out. What's the difference between a river and a pond? Don't make it complicated. Because a pond is stagnant. A river is in a constant state of flow. The human body is a river system. It must constantly in a constant flow. So when you're having blood pooling back down into your legs and you have all this swollen feet and leg, that blood is pooling up there. It adds up. And there's ramifications of blood pooling in the leg. This is just basically your muscles, right? And as you ambulate and you're walking and you're active, that muscles contracts, it squeezes the vein. And that system additionally helps propel the blood upwards back to the heart. So yes, men and women will experience venous disease at some form, right? Whether you have all these little spider veins, they start to look a little larger, they start a little bulgier, it doesn't matter. They'll have some form of venous disease by the time they're well into their 60s. Again, even if you look at the risk factors, stand-in profession, obesity, family history, multiple pregnancies, trauma, patients with knee replacement because of all those vein systems that they have to tie off. Ultimately, eventually, for some reason, these patients go on to develop venous insufficiency. Patients with ankle surgery, broken ankle, with major ankle surgery. Recently, data have come out to show that patients who've undergone coronary artery bypass surgery because they've stripped these veins out of their leg for the bypass almost 10 years later, those patients will go on to develop venous insufficiency as well. So you can add that on to the risk factor. So, when you're sort of looking at, 2009, 10, 11, and 12, technology advanced, and so everyone is sitting there going, well, you know what? We have to do something about venous disease. It's a major problem in the United States. When you have 24 million people running around not being treated, yeah, it is a problem. It's not like, you got 100,000 patients and you're trying to figure out what to do. You've got 24 million people costing you billions of dollars and you're not able to treat that disease. You got to do something about it. Now, if you're able to see this slide, even though it's a little fuzzy, it actually even reinforces the point. When you look at this slide, you sort of think about vascular disease, right? You think about coronary artery disease, carotid artery disease, peripheral vascular disease. But then look where coronary artery disease is. Right? Look, peripheral vascular, carotid disease, right? And heart disease. Look where venous reflux disease is. And I'll give you a perfect example to compare this to. When we talk about smoking, right? Because there's such a public awareness for decades now. Smoking, lung disease, right? Smoking, bronchitis. Smoking, emphysema, right? Or COPD. But believe it or not, there's more disease actually from peripheral vascular disease related to smoking than everything else that I just mentioned. Symptoms. And it's a stage. Venous disease has this stage. It has 6 stages, right? And this came up. This was revamped about 6, 7, 8 years ago by the World Health Organization, or WHO. And they have stage 1, stage 2, stage 3, 4, 5, and 6. 4, 5, and 6 is when you start to see that skin discoloration, right? So if you have a Caucasian patient with that light skin texture, but you start to have these golden brownish pigment deposits in the skin, that's going to be 4. Then you see it a little bit more advanced, and then it start to become a little darkish. And I think we have some other slides to show it, but you can see how it advances. Pain, it's usually never pain, it's more of an achiness, heaviness, and fatigue and tiredness. So use myself as an example. If I'm standing here and I have venous insufficiency as I'm standing here, the longer I stand, that reflux is trickling down. It's a little trickle. It's like that little sink that you remember you had that was so annoying, it just drips, right? So that reflux will drip, and there's a cumulative effect of it. So 5 hours later, your legs are swollen and heavy. Achiness. Patients always complain. 4 or 5 o'clock in the afternoon, I can't do anything. My legs are just exhausted because they're swollen. That's exactly what it is. By the time they get home, they're just sitting there rubbing their leg because it hurts. It's heavy. It's achy. Venous disease is very unique. And the classic location for venous disease, when you break out into the ulcer, it's usually on the inner aspect of the ankle. If you remember the picture that I showed earlier about the great saphenous vein, if you look at the anatomy where it runs on the inside of the foot upwards. And gravity falls at the point of the lowest, right? When you throw something up, it's not going to fall and stop down here. It's going to stop at the end point on the floor. So this is going to be the end point area as to where the blood will pool. And that's the area. So the issue is, why do people develop venous ulcers? What is it that how does this disease behave in such a way that your end result is pretty, and I was very generous when I pulled this slide out, actually. When you start to go through the varicose veins, and then a little bit of swelling, and the swelling goes on more. And that's why I use the example of a river and a pond, because as the ankle and the foot, the leg is swollen, that blood has products, it has components. So when that blood breaks down, it releases chemicals, it releases inflammatory chemicals. So if you ever notice, one of the common things the patient always get admitted to the hospital is for cellulitis of the leg. Well, it's not really cellulitis of the leg. It's an inflammatory process secondary to all that blood that is pooling in the leg. That's why a lot of times you may see people, their legs are swollen and red and blistered. Now, those chemicals are very detrimental to the skin, because basically it gets deposited into the skin. All that chemicals, all that cytokines, all that pro-inflammatory. And then there's a skin deposit, there's a sort of a pigment deposit. It's called a fibrin. When that skin products break down, it has nowhere to go. So it gets deposited into the skin. So that's where you see that transition from a normal, healthy skin to that slow process. It's almost like a cayenne, golden, brownish deposit. It's slow. And then it adds up and it adds up and it adds up over years and years. And then that skin continues to go through that process of discoloration. But if you put the effort in and you diagnose and you treat the patient the proper way, you can make process and you can heal the patient. You can heal the wound. But that was 10 years ago, right? Everybody got happy, and the doctor gets some cookie and some brownies for doing a good job. Except for when the patient shows up 6 months later with a new wound. So what are some of the treatment plans when you have patients with venous disease? One, it's the common elevate your leg. Supportive stockings is very important, but you have to know your patients. If your patient has bad arthritis, write to the patient a prescription and tell them, well, I want you to wear 15 to 20, or 25, or 20 to 30. The patient's not going to wear it. So you got to know your patient. Ask your patient, what is your strength? What is your ability? Are you able to grab and hold it and pull it up? Because these things are tight, because they're pressure graded. So there is a tightness. So be fair to your patient, and I have to be very fair to my patients, and I ask them. Now, if you think about everything that we talked about, in terms of the physiology, the veins, the valve, you'll see why stockings is important. Now, stockings doesn't cure the disease. It doesn't cure the disease. What it does for the patient is to improve their quality of life by reducing the swelling of the leg. Because remember, what makes the disease so annoying? Heaviness, fatigue, tiredness. From what? From swelling. That support stockings, when you put it on first thing in the morning, when your leg is not as swollen, and you can keep it down with that supportive stockings, it improves your quality of life. It makes you feel better. Or I always tell my patient, put one on one leg and don't put the other one on the other leg and see what happens. Then you'll really have an idea of what's going on. So stockings are important if you're able to put it on, and make the effort. Of course, like anything else, if you have high blood pressure and you don't take your medication, then your blood pressure is going to be high, right? If your cholesterol is high and you're not taking your medication, then your cholesterol is going to go up, right? So if you're not compliant with, whether you're going to do the leg elevation, walking, being as active as much as possible, trying to keep your stockings as much as possible, then compliance is going to be a problem. Then obviously the disease is going to continue to progress and you're going to get that end result. It's never a quick fix. It's a long-term care with the patient. You got to see your patients. You got to follow up your patients. And how do you do that? Well, there you go, modern technology. Look at that ultrasound today versus an ultrasound 10 years ago. It was almost like computers. If you go look at old computers like IBM, it was a big square box. Well, it's no difference now. We have laptop and we got Palm Pilot or iPod or whatever it is that they have. But the ultrasounds, you can do these studies at the bedside. Again, this is only a technology that came out in the last 4 to 5 years. And it's actually in the last 3 to 4 years, I've gotten even more better and much more crisper. And you can actually diagnose now exactly what's going on. You can look at that great saphenous vein. You can look at that small saphenous vein, and you can see how that valve is behaving. You can actually see how the blood is flowing. You can see whether it's coming back in reflux in. Technology, right? But you got to be a skilled physician to know how to use the ultrasound. Because honestly, in the Valley, not everybody can do this study. Not every hospital, not every tech knows how to do this study. So you got to make sure who's performing it actually knows how to do it. Plus you got to know what you're looking for too as well. Now, this is reflux on the ultrasound, right? So when that study is when you're in the physician's office and you're having that study done, this is normal. When you squeeze the physician will squeeze your leg with the ultrasound on the vein. That's normal. When he squeezes and releases it, it should continue to be normal if it's a healthy functioning valve, right? If the vein is functioning, it should continue, right? But if you see this and it goes up, then this is the opposite of normal. So that's reflux, right? So what you do with your machine is you press click here and you drag it all the way to the end, and the machine will actually calculate centimeter per second. If it's greater than 0.5 centimeter per second, that is a significant venous reflux. There's the answer. That's how technology has changed. Simple study. As my son would always say from that commercial, such a simple word, row. You ever seen that commercial? Such a simple study. Reflux. Treatment plan. You guys all live in a big city in Fresno. You've probably seen all the ads. You've seen it in your Sunday. Everybody's an expert with varicose veins. So you can treat it, yes. You can do sclerotherapy, you can do external laser, foam injection, all sort of fancy technology. But remember, where the problem is, it's in the main pipe, the main venous system. So if you're getting injections and you're spending hundreds and hundreds of dollars on on injections, they're really not paying attention to the main system, the main problem. If the main pipes are okay and you have venous disease, yes, you know, all these laser and spider vein injections and so forth cosmetically works well. But they owe it to you at least to check your great saphenous or small saphenous. And that's what comes in what we use in terms of the medical technology. What is it that we do for patients with venous disease? Once that study is positive, depends on your insurance, because each insurance carrier has different criteria, right? So you have to have documentation. Overall, between Medicare and all your private insurance is 3 months. They want you to wear your support stockings. They want you to be a loving, kind, good patient, that you put on your stockings every day. It's not like they're looking through your window with a scope. Is she wearing her stockings? But she's not compliant, you know? No. It's really because it's to your advantage, because the idea is you take the benefit of the support stockings, you take the benefit of the procedure, and you put it together, and it enhances the outcome of the patient, right? So what is it that we actually do? Well, under the ultrasound, we find the incompetent vein. Is it the great saphenous vein is incompetent, or is it the small saphenous vein? And just like having an IV stick, we puncture that vein, we pass a wire in, we put a heat probe in, and the actual procedure is 1 minute and 20 seconds if it's up here, and it's probably no more than 60 seconds here, and the actual procedure is over and done. And all you have is a little tiny puncture at the skin. You come in the office, and you walk right out of the office after the procedure. The most time they spend in the recovery room in the office is probably 10 minutes to make sure they're okay. They get a nice cup of tea, or iced tea, or whatever the delight is, and they're happy, and they go home. And that's really is. That's the actual puncture. Everybody feels good, and they go home. And it depends on how bad your venous disease is. If you have really bad venous disease and you have very bad swollen leg, patients will come back within 72 hours and they'll tell us, my swelling is so much better. And some other patients, it'll take maybe a week or so, they'll start to see the benefit. There are different equipments out in the market, to each their own. There's the laser system that has a higher heat wave frequency, and there's the radio frequency ablation. This is done by, which is known as the venous closure device. This is made by Covidian. Statistically across the country, I would say 7 out of 10 physicians who actually do this procedure will use the venous system. And one of the advantage is less bruising. The laser, they're sort of going through a new generation trying to remove that stigma of that bruising that they get with their patients with the laser, because of the high heat. A lot of patients get a lot of bad bruising. So not kind of nice to see when your patient come back, there's a big bruise there. But for us, the venous system is very easy to use. You don't have to be in a room, dark and have on dark glass because of the laser and all that stuff. And there's always indications and contraindications. For every good, there's always going to be a bad, right? So if patients have a clot in their leg or a known history in that vein, in that great saphenous vein or that small saphenous vein, well, you don't want to be doing a venous ablation on those patients because you can promote more clots and it can actually break off and go up to the lung. And you end up with a pulmonary embolism. Very rare. Very, very, very rare. But it's up to the physician who's doing the study. Again, he must be well trained in ultrasound that he can look at your vein system to make sure that there's no underlying clot or thrombus there. There's always safety. There's always potential risks and complications. You know, as people are entering the vein and they're passing a wire or they're passing the probe to perform the procedure, if they're not very careful and they're not very gentle or they're not following it under the ultrasound, and they hit a valve, because you have to pass through the valves. And sometimes some of the valves are very thickened and inflamed. And so as the catheter is coming through, it's stuck in the vein, on the valve, excuse me. And so sometimes you want to give it the old, and it will work. But then once in a while, if you give it a little bit, you can actually perforate the vein. And that pretty much puts an end to the procedure because now you got a big hematoma. There are a risk of having deep vein thrombosis from the ablation. That percentage-wise is probably way less than 1%, probably even less than 0.5%. And obviously, that if you have a DVT, the risk of that clot breaking off at the junction and shooting up to the lungs is always there. Phlebitis, very rarely. Some patients, the patients with those big snaky varicose veins, as you knock off the main pipe, they don't have that communication route anymore to drain in. So whatever blood is trapped in that varicose veins, it's sort of within a week or 2 weeks, it starts to get hard and rubbery. And so whatever blood products is stuck in that varicose veins, it starts to act up and get upset and release chemicals, and it starts to appear somewhat red. And then you just tell the patient, don't worry, just take some anti-inflammatory or some cool packs, and over time it will subside. Hematoma, very rare, and that's from the puncture site. Sometimes you'll puncture right over a vein as you go through. You just have to be careful that you don't do that. Nerve injuries, based on the anatomy and the way that vein system runs in the thigh, it's very far off from the nerve area. The reason why I think nerve is there is someone who is very careless and probably don't know their anatomy. And I just have to be honest. I'm a vascular surgeon, so I do have to be biased. If I'm a vascular surgeon, that means I know all my anatomical structure. There are a lot of people out there who are not surgeons. You know, there's people who are non-surgeons who are doing these procedures. It does not necessarily mean when they stick that needle in there, they know exactly where things are. So sometimes they may overstick or over-inject the patient and might be very near a nerve. Think about it when you go to your dentist and they stick that needle up your gum and it hit the nerve, and then you kind of like, you ain't coming back here anymore. Anytime you puncture the skin or you violate the skin, there's always risk of infection. You got to make sure your patient gets some form of preoperative antibiotics. Skin burn, right? So whether you're using the laser or the venous system, you have to know your catheter. There's a heat probe at the end of that catheter. It's a long delivery system, and it has a sort of a copper, is it copper? Yes. Copper tip, right? So as you're coming out towards the skin, for the most part, the average patient will be about 0.5 centimeter. That vein runs about 0.5 centimeter in the thigh underneath the skin. And you have a working sheath. I don't know, I think you probably have seen it. This one here. This is your working sheath, right? And that's your tip, right? So as you start to back that catheter out and you're performing your procedure, you got to make sure that this tip is not coming out towards the patient's skin. The closer that heat probe is towards the skin, there's an increased risk of burning. Because for the venous closure device, it functions at 100 degrees Celsius, 120 degrees Celsius. Now, when you do that procedure, we do inject fluid, a special prepared solution that goes around that heat probe to buffer the heat, to protect the muscle and to protect the nerve. So if you have nerve problem, your physician did not inject the solution properly around that vein and around that probe. So when you activate that machine at 120 degrees Celsius, it'll send a heat down to the nerve. It can actually cause a thermal burn. About us, you can find us many ways. You can find us on our website, Facebook. I think we're on Twitter. Now, going back to your question and your question about DVT. It's called Virchow's triad. Don't ask me how to spell Virchow. It's V-I-R-C-H-O-W, Virchow's triad. It is known as intimal injury to the vein, the wall. If you think about a patient, why do patients get plaque? Why do patients get atherosclerosis or blockages in the artery? Because an initial injury to the vessel creates a physiologic response where platelets, things that when you get cut and you hold pressure there and it clots, those are platelets. They have chemicals, certain chemicals or adhesive component. The body does that as a protective mechanism. So when you have a bruise in the wall of the vessel, a plaque will form, right? Or a clot because of whatever reason or for that injury. And a clot begottens a clot and a clot and a clot. But you have a clot there and there's flow flying by. Boom, it hits it off and it goes.
Part of the clot breaks off and goes down the bloodstream.
Right up and straight up into your lungs. That's how you get a pulmonary embolism. So it starts off as an initial injury to that vessel wall. It's no different than your coronary arteries. Initial injury, right? When you're smoking, you're damaging the wall of the artery. So every time you damage the wall of the artery, the body is trying to repair that damage by adding plugs, right?
How does smoking damage the artery? Is it the chemicals that the smoke?
Yeah, if you look at there's algorithms in the vascular text, and it almost looks like a tree upside down with 4,000 branches. And that's because the nicotine initiates all these inflammatory chemicals in the body that creates this huge cascade. And it releases all sort of weird protein and proteinase, and it ultimately damages your collagen production. And so you go from a high collagen production to a low collagen production to a low elastin that's supposed to keep your artery nice and healthy. So you end up having a low elastin, therefore you have a very weak vessel wall.
And hard? Is it hard too?
Well, that's because of the plaque will build up over time. Yeah.